Thank you so much to the group for inviting me here today and to be able to speak a little bit about trauma and trauma-informed care. I have no place of interest to disclose. So I just want to start with this quotation by Vince Felitti, who is one of the co-authors of the Adverse Childhood Events study, which is a real seminal public health study. And because I think it really underscores and captures kind of the importance and the relevance of trauma and early childhood experiences in understanding later health, both mental health and physical health. It's hard to talk about trauma-informed care without speaking about the ACEs study. So, and I'm sure that many of you are familiar with it, but I just want to point out a few things just really briefly before we get into the specifics of trauma-informed care. So the ACEs study was originally, it was conducted at Kaiser Permanente in the 1990s. It's a very large sample, 17,000 adults. It's a retrospective, or was a retrospective study that asked patients about these 10 categories of early adverse childhood events. And I think that you know, when the researchers set out on this study, they really had no idea kind of how common so many of these experiences really are. And I think that I think that, you know, it's just been such a critical piece for really understanding the importance of trauma that I think it just needs to be emphasized. And so here I just want to show the breakdown, because one of the most important things, or one of the things that came out of the ACEs study was just, again, how common these experiences are. So on the left-hand side here, we see 3 different kinds of abuse. So we see psychological abuse, physical abuse, and sexual abuse. So you can see this is, you know, what people are reporting, just frequency levels, that physical abuse is the most common type of adverse childhood event that is endorsed. And then for household challenges, we have I think it's domestic violence at 13%, witnessing domestic violence. Having a parent or caregiver with a substance use is at 27%. So almost, you know, the second highest of these reported difficulties. And then we have parent with a psychiatric illness at 19%, divorce at 23%, parent incarcerated at 5%, and then feeling unloved or unwanted at 15%, and physical neglect at 10%. So ACE scores, as a lot of you know, they are typically presented as kind of looking at a cumulative risk. So the total amount of stress during childhood, so we think about how many ACEs people tend to have. So about 2/3 of this population reported at least one ACE, and then of those, about 1/3 reported 3 or more ACEs. And I think, again, so the 2 really big take-homes from the ACEs study. One is that these problems are extremely common. People are reporting, you know, really large numbers of them, and we know that there's a graded relationship, so that it's cumulative, so that the more adversity one experiences, so to speak, the greater the risk for all kinds of kind of negative health outcomes, both mental health and physical, later in adulthood. And I think this is just, you know, one example that the risk of disease if a person has 4 or more ACEs compared to 0. And so I think this is where we really kind of see across the range. So for obesity, risk for smoking, greater number of sexual partners and STDs, alcohol, drug abuse, depression, suicide attempts, etc. So moving into PTSD, so post-traumatic stress disorder, which is not the only outcome from early or early adverse experiences or trauma, but it is the most common. And I think this is a powerful kind of statement for me to remember that that 24.4 million people have PTSD at any given time, which is equal to the total population of Texas. Okay, so this is not an uncommon disorder that people are experiencing, and that it is much more common in women than in men. And another kind of prevalence figure to think about is that about 70% of adults will endorse having experienced some kind of traumatic event. And men are more likely to experience traumatic events, women are more likely to develop PTSD. About 20% of people who experience a trauma will develop PTSD, but these are some of our risk factors. So I think, again, for all of you to think about in your populations, kind of that these are risk factors that increase the likelihood that somebody may have PTSD. So as I said, women, sexual trauma, having a prior trauma, so definitely that again, you see that cumulative effect. A prior psychiatric disorder, depression, anxiety, or substance use disorder, family history of mental health disorders, the severity of the trauma, and lack of social support. So what does it mean to be trauma-informed? So thinking about, how common trauma is, I think it's a really, particularly in the healthcare field, but also across lots of different service systems, we've really started to think about how do we deliver care? How do we think about interfacing with our populations that actually takes into account people's traumatic experiences in a more effective way? And so this is really, it's kind of a philosophical shift, and it's a very much of a whole person view. So instead of really coming in and just thinking about what the symptoms are that somebody presents with, or when somebody's illness is, we really want to take a more contextual view and really think about, not just what are they appearing with today, but really trying to understand their story. And because as we know, that really does impact the kinds of problems that they may be presenting to primary care with. So a couple of different things to think about in a trauma-informed approach to care. We want staff and providers to realize how common trauma is, and that a lot of the symptoms that we see with trauma, and a lot of even PTSD symptoms, are understood as ways of coping, particularly at a point in time that they had a function, and that they are not just a psychiatric symptom that has no use. I think that becomes a really important piece, and I think it also builds empathy for being able to understand people with traumatic pasts. Recognizing the signs of trauma, so you can see certainly there's a need for training. So really being able to understand, what does trauma look like, how do we understand how people get triggered, and how, of course, how does it manifest? And then how do we respond in the most trauma-sensitive way? So thinking about our language, our behavior, the settings that we're working in, the things that we're asking patients to do, and I'll get to that in a minute about medical settings. And then resisting re-traumatization. So I don't think any of us in the healthcare profession set out to re-traumatize. That is not something that's done intentionally. However, I think there have been a number of studies that have looked at what patients' experiences are of different medical procedures and things like that, and that people will report that there was kind of a re-traumatizing aspect to that. So that's the way it's experienced. It can be the subjective experience. Another kind of way to think about trauma-informed care is that these are kind of our key principles. So sort of this is necessary, but not sufficient, and sort of values of trauma-informed care, that we really want to think about safety, not just of patients, but also of staff and providers. There's a big emphasis with trauma-informed care on taking care of staff and thinking about staff wellness, burnout, compassion fatigue, things like that, because with the idea that it's hard to be trauma sensitive for patients if we're not feeling if we're not feeling safe and trusting of our colleagues as well, and also thinking about safety as both physical and psychological. Trust and transparency. Again, I think both among ourselves, staff and providers, and with our patients. Patient choice. Collaboration. So lots of collaboration, recognizing that we alone cannot meet all the needs of our trauma-impacted patients, and so we really need to be collaborating with community-based agencies and other providers, and empowerment. Just these are some things to think about in terms of medical settings, and these can serve as triggers. Again, not for everybody. That's the thing about triggers, is that they can really vary depending on what people's traumatic experiences have been. But things like invasive procedures, removal of clothing, touch, coming up from behind and touching a patient, questions, asking a lot of sensitive questions, particularly with a healthcare provider that's not as well known to somebody. Lots of power dynamics in terms of thinking about, the doctor-patient relationship. And if you think about interpersonal trauma, a lot of that happens in a power differential. So it's an authority figure who has actually perpetrated, let's say, against, like a parent and a child, let's say. And so sometimes that power dynamic in and of itself can be a trigger. So just the benefits of a trauma-informed approach, that people are doing more and more research in this area, and we are starting to find improvements for patients in patient engagement. Taking a trauma-informed approach is increasing our ability to engage particularly difficult to reach patients. Treatment adherence and healthcare outcomes. And then we're also seeing improvements for staff and providers. So providers working in a trauma-informed clinic are experiencing more job satisfaction, wellness, reduced burnout.